Good afternoon, everybody. I'll be speaking about CABG versus multivessel PCI in the setting of a stable coronary artery disease. I think the acute coronary syndrome's ST elevation MI is already covered by Dr. Ramchandra. This is based on the guidelines available as of now. Now, most of my talk will be based on the recent 2018 ESC guidelines which have come out in this August, and also the ACC-AHA guidelines appropriate usage criteria which was given out in 2017. So before I go ahead and speak about which mode of revascularization should be used, let me just revisit what are the indications for revascularization. What are the situations where we should revascularize the patient? Then we can decide which type of revascularization will be good. So what the guideline says that if there is a patient who is symptomatic despite medical therapy, then this is a definite indication for going ahead and revascularizing this patient. There's no doubt about it. And what about patients who are not symptomatic? So in those patients where there is a survival benefit, we have to go ahead and revascularize them. So what are those subset of patients where there is a survival benefit? If you look at the data, patients who have significant left main disease, there is a definite survival benefit out of revascularizing them. Patients who have a significant proximal LAD stenosis, there is a definite survival benefit, so we have to revascularize them. In the other individuals who have 2 or 3 vessel disease, with or without proximal LAD, when there is a significant LV dysfunction with an ejection fraction of less than 35%. So there again there is a survival benefit. So these are the situations where we have to definitely revascularize, irrespective of whether the patient is symptomatic or asymptomatic. If you look at the ESC guidelines, they say stenosis of more than 50%, and if you look at the ACC-AHA guidelines, they say stenosis of more than 70%. Now, one thing I want to point out here is, in all these patients, we have to demonstrate ischemia. Ischemia either shown on non-invasive tests like a stress thallium or a dobutamine stress echo, or on-table fractional flow reserve. So if you have a significant ischemia which is documented with a stenosis of more than 50% in the areas where I've shown, that's a definite indication for revascularization. Now, apart from that, if you have a large area of ischemia which is involving more than 10% of the left ventricle, there again there is a survival benefit shown in some of the studies, although the evidence is not as strong as what it was in the previous situations, but definitely that's another indication where we need to revascularize. Similarly, a single remaining coronary artery with a stenosis of more than 50% is again an indication for revascularization. So these are the situations where revascularization should be done. Now, one more point which I would like to point out, which is emphasized very well in these guidelines, is the usage of functional testing. When evidence of ischemia is not available, FFR is recommended to assess the hemodynamic relevance of the intermediate grade lesions. So many times, we sometimes tend to go only by what is seen on the angiogram, but that may not always be right. So it is better to use FFR wherever possible. Why? If you look at these slides, you can see in the first example here, you have lesions which are looking pretty similar. They're borderline here. If you look at the LAD and the RCA, they're looking like an intermediate kind of lesion. But if you check the FFR, it is very significant in this LAD, and if you check the FFR here, it's not so significant. Similarly, in another example you see here, the LAD, there is a lesion, but the RCA angiographically looks more severe compared to the LAD. But if you look at the FFR, it's very significant in the LAD, and it's not so significant in the RCA. So sometimes our decisions do change based on the functional testing, and that's why it is important to incorporate the functional testing as a part of our protocol while deciding on revascularization and the mode of revascularization. Now, while deciding between PCI and CABG, so what are the criteria which we take for deciding which modality of revascularization which we choose? One is the predicted surgical mortality, then the anatomical complexity of the coronary artery disease, the completeness of revascularization, and of course the clinical characteristics of these patients. So these are the major criteria by which we decide which modality of revascularization we should choose. Now, the predicted surgical mortality can be assessed by different scores, The most commonly available one is the STS score, Society of Thoracic Surgeons score, or the Euro 2 score. Between the two, STS score is the one which is most commonly used for assessing the surgical mortality. So if you have a mortality which is predicted to be more than 5% by surgery, that's a situation where we consider it as a high risk for CABG, and definitely PCI should be an option which should be considered. Similarly, the anatomical complexity assessment is most commonly done by the syntax score. I'm sure all of you are aware of this. Now in the syntax score, what we basically do is we look at the location of the lesion, and we also look at different parameters which tell us about the complexity of the lesion, which includes whether it's a bifurcation or a trifurcation, whether it's a chronic total occlusion, whether it's an hypoosteal lesion, the extent of angulation, length, calcification, thrombus. So there's a score for all these, and based on that we calculate the syntax score. So up to 22 syntax score, we take it as a low syntax score. 23 to 32, we take it as an intermediate syntax score, and 33 or more, we take it as a high syntax score. Now, as we can see, in the low syntax scores, the outcomes are pretty similar between the CABG and the PCI. Now, as the syntax score increases, you can see the curves diverging, and in very high syntax score, the outcomes are totally different in PCI versus CABG. So syntax score is an important parameter by which we decide which form of revascularization we should choose. Now, one more thing which I would like to stress is the regular syntax score doesn't involve the physiological testing, and it also doesn't involve the clinical parameters of the patient. So to improve on that, a functional syntax score has been proposed where we do FFR for all these lesions. And what has been observed is, without FFR, if what we are seeing here is the kind of distribution which we get in a particular study. Now with FFR, actually we see that the syntax scores come down. So our decision of whether to go for a CABG or a PCI might change. Now another important parameter is the completeness of the revascularization. What do you mean by complete revascularization? If you have a vessel which is 1.5 millimeters or more, and if there is a significant ischemia which is demonstrated, that vessel should be revascularized. So if you revascularize all these vessels, then we call it as a complete revascularization. And it is shown very well in several studies that a complete revascularization always improves the outcome in patients. And similarly, clinical characteristics, the most important of that being the diabetes, will help us in making a decision whether to go for a CABG or surgery. So what the guidelines say is that it is essential that we look at the surgical risk by an STS score preferably, or Euro score 2 as an alternative. And we should also look at the lesion complexity as assessed by the syntax score. And we should also look at whether we can revascularize the patient completely or not. So these are the parameters we should take before deciding whether to go for a CABG or PCI. So now when you have patients who are suitable for both, so what are the conditions where we choose to go for a CABG? Among the clinical characteristics, presence of a diabetes will tilt the scale more in favor of a CABG, reduced rejection fraction less than 35%, contraindication for a dual antiplatelet therapy, and recurrent diffuse instant restenosis. These are the situations where CABG might be better compared to the PCI. Similarly, the anatomical aspects where the syntax score is more than 23 is again more in favor of a CABG. And presence of other comorbid issues which like a valve repair or any aneurysmal surgery will also tilt the scales more in favor of a CABG. Now for PCI, presence of other comorbidities which increase the surgical risk will be a factor which goes more in favor of a PCI. And of course the complexity of the lesion as assessed by the syntax score. So among patients who are suitable for both the procedures, and if the surgical mortality is low, how do we decide which modality should be chosen? Now what the guidelines say is that if you have a single vessel disease and there is involvement of the proximal LAD, here angioplasty would be a preferred choice, but surgery can be an alternative which can be considered. That is with proximal LAD stenosis. Patients with a single vessel disease with proximal LAD stenosis, we can either go in for either surgery or angioplasty, and both of them have similar weight. But those patients who have lesions, single vessel disease without proximal LAD stenosis, obviously angioplasty is the treatment of choice. In those patients who have a two-vessel disease, without proximal LAD stenosis, angioplasty is the preferred mode of revascularization. And in those patients who have two-vessel disease, but with proximal LAD stenosis, both angioplasty and surgery can be good options. Now, patients with the left main disease, where the syntax score is less than 22, both angioplasty and CABG will be reasonably good options. They're equally good. But in patients with a higher syntax scores, then surgery clearly scores compared to the angioplasty. Now, in the intermediate syntax score, we can discuss with the patient and where the choice of the patient may also matter, but in a high syntax score, definitely surgery is clearly the winner. Now, in patients who have a three-vessel disease without diabetes mellitus, if the syntax score is less than 22, then angioplasty is as good as surgery. But in patients who have a syntax score which is more than 22, even if they're non-diabetics, then surgery has an advantage. In three-vessel disease with diabetes mellitus, clearly surgery has an advantage compared to the angioplasty. But these are all guidelines. Ultimately, what we do in a given patient depends on the patient's choice as well as the other parameters, clinical parameters which we have discussed. Thank you.